Hi. Acute coronary syndrome is a group of clinical symptoms that are compatible with myocardial ischemia or unstable angina and non-ST elevation MIs and ST elevation MIs, or better known as Stemis. And acute coronary syndrome is the manifestation of coronary atherosclerosis. And atherosclerosis is the process of where plaque forms in the arteries, mainly in the medium and the large size arteries. And the risk factors that influence this process of plaque formation are things such as high cholesterol, hypertension, diabetes, smoking. And all of these risk factors, they damage the blood vessels, which leads to dysfunction of that vessel, and it can cause erosion where the plaque breaks loose, or sometimes the plaque just ruptures. There's a lot of cellular activity that happens and causes inflammation that causes wear and tear on that vessel, and that's what causes the plaque to erode or to rupture. And then when this happens and all the inflammation and the platelets come in and adhere to the plaque, and it forms a clot, and then this clot will block an artery that leads into the heart. And when that happens, the heart muscle cannot get the blood, gets no blood flow or oxygen to it, and the cells begin to quickly die, and the muscle of the heart dies and is permanently damaged. So when you hear that time is muscle, what that means is it's very important that we do not waste any time with getting that artery that is blocked open and reperfusing the heart muscle, getting the blood flowing back, getting the oxygen to that area of the heart, so that we can prevent as little damage as possible and cellular death. When somebody presents to the ER, or if they're in the hospital and they complain of chest pain while they're in the hospital for something else, our goal is, from the time that patient complains of chest pain or back pain or neck pain, whatever led us to do the EKG and we found that they were having an ST elevation MI, our goal is from that point to have them on the table in the cath lab and ballooned or stented open, with the artery open within 90 minutes. So sometimes though people present to an ER where they don't have the capabilities of a cath lab, and if the next facility where they can get into the cath lab and get stented and open, get that artery open back up, if it's too far away, sometimes the best choice is to go with using a clot buster, which we used to use years ago. And there are risks with clot busters, risk of bleeding. If someone's had a hemorrhagic stroke within 3 months, they cannot be given these clot busting drugs. If they have an aneurysm, recent surgeries, sometimes if they're on blood, heavy duty blood thinners, there's just different things that make the patient too high of a risk to give these clot busters. So the best case scenario is to get the patient to the cardiac cath lab and get the balloon in place, get them stented, get it opened up so that the blood can get into the heart and restore and prevent any cellular damage or muscle damage of the heart, which would be permanent.